All right, we'll get started. So good morning, everyone, and thanks so much for joining the STEGH Foundation and Hospital's STEGH Talks virtual session. Quick housekeeping before we begin. Because we have such a large group attending today, we're going to be muting everyone except our presenters, Dr.Carroll Harder and Stacey Adamache. If you have any questions during our presentation, please type them in the chat field and we will try to answer as many questions as we can during the Q&A. And FYI that this session will be recorded and shared at a later date on our YouTube channel. I would now like to introduce STEGH Foundation Chair of the Board, Judy Thorner, who will be introducing today's special guests.
Good morning, everyone. And on behalf of the STEGH's Foundation's Board of Directors and staff, welcome and thank you for joining us today for STEGH's Talk. This morning, it's my pleasure to introduce Dr. Carroll Harder, who works in the STEGH's Emergency Department and Chemotherapy Unit, and Stacey Adamache, Manager of Ambulatory Services at STEGH. Together, they will be presenting Cancer Care Close to Home. Dr. Harder and Stacey, welcome.
Thank you. Kenzie, are you, if I share my screen. There we go.
Perfect.
Sorry. I just have to, how is that? Can you see the slide deck?
Looks great.
Properly? Okay, perfect. Good. All right, Carol, I'll let you go first.
Yeah, for sure. I'm Carroll Harder and glad to be presenting today and just sharing some information about our chemotherapy unit here at STEGH. Just to chat briefly about our team, we have clinical resource nurses. So these are nurses that have special chemotherapy certifications that they have to renew every few years. They are required to do a certain amount of hours in their clinic in order to ensure ongoing competency. And so we have 6 registered nurses. We have a booking or a registration clerk who's very much involved in all aspects of running the clinic and answering phone calls and triaging those phone calls. We have a charge nurse who's sort of the educational piece. I don't think they use the term charge, though. I think it's more of a lead nurse that they have assigned to sort of do scheduling, to work with the other nurses in order to ensure the ongoing competency and that the flow of the clinic. And we have a pharmacist who is in the clinic during the times that we are running chemotherapy. We'll talk a little bit more about that later, but they are there with us physically. And then we have physicians who are GPOs or general practitioners in oncology. This is a designation that requires extra education in order to support those patients requiring chemotherapy and managing those specific types of medications, side effects, symptom management. And this education happens in concert with the LRCP, or the London Regional Cancer Program. They are sort of our link to that education piece and the ongoing maintenance of education. So at STEGH, we have 4 GPOs. We have support from some of the previous physicians that are now retired. But most of us at this point are doing, or all of us, I should say, are doing this as a chemotherapy as a part of our wider practice. So we all have other positions as well, as Judy mentioned earlier. I also work in the emergency department, and that sort of would be my primary position at STEGH. But this is also something that each of us does as a sort of part of our practice. In addition, in the last year or so, we've had a medical oncologist that trained in London join our team, and she has specialty in breast and GI cancers. And so Dr. Panaganti also runs her clinic on Thursdays in our chemotherapy unit, and her patients are also seen and followed by us in St. Thomas.
All right, so a little bit about our chemotherapy unit. So our unit is in the South Building, as you can see, near ambulatory care, so at the other end of the hall. And so we have our treatment room with our 8 chemo chairs. We also have a stretcher for patients who prefer to lay down during their treatment. Just depends on how patients feel that day and what would make them most comfortable. So we're very cognizant of that. Our clinic space has the exam rooms there, and that helps facilitate patients or conversations between patients, their loved ones, and the care team. Obviously, those patients can be somewhat sensitive due to the nature of why patients are coming to see us. And we encourage patients to bring an essential caregiver, at least to their initial visit, because there's always a lot of questions, and not everybody can remember really what's being discussed, given the gravity of the conversations. So that ensures privacy for those personal conversations, and that can happen before, during treatment, and during follow-up at any point that there's any decisions being made about what needs to happen while patients are with us. So we're open Monday through Thursday. We run chemo and clinics on Monday through Wednesday, so 3 chemo days, an infusion and a clinic day on Thursday. So we don't give chemo on Thursdays for various reasons. We do open on some Fridays when there's a holiday, usually a holiday Monday. That helps us make sure that patients are staying on the right sequence for their chemo treatments. There's a lot of specific timing that goes into a chemo regimen. So opening on Fridays, so we don't lose a day during the holiday week, is definitely helpful to keep us on track for those patients.
I mentioned earlier the pharmacist that sits in the chemo unit with us. This is a definitely an intrinsic role for our team, and they work collaboratively with us in our role of managing the regimen, making sure the dosages are correct, ensuring best patient outcomes. So this close interaction between the physicians, the nurses, and the pharmacists helps us make sure that everything is done accurately. The lab results are adequate to proceed. We're looking at drug interactions. The technicians can document all of the home medications to ensure that we have the most up-to-date information and approval of funding for drugs for various conditions. A lot of this starts at LRCP with their pharmacy team, and then sort of our pharmacy team is able to take over and ensure that our hospital has the funding to do the treatments as they're required.
We also rely on our volunteers. So we are thankful to have them back in the building now. 18 months into COVID, we've missed having them here. So we have a core team of volunteers that rotate through the department every day that we're open, and their hours down with us are 10 to 2 o'clock. So that helps during sort of the peak times when we're registering people, getting them into the clinic area, and then getting them across to the treatment area. So one critical role that they perform is transporting our blood work samples to the lab. We want to get those lab specimens up to the lab as soon as possible. As you know, think about where the South Building is and where the lab is in the main tower. It's quite a ways to walk. So we're thankful for them to get that blood up as soon as possible. A lot of the treatment regimens can be quite lengthy, multiple medications or medications that need to be transfused over a long period of time. So it's really important that we get the lab specimens up to the lab and processed as quickly as possible, so that patients aren't spending more time here at STEGH than is necessary. Time is a very valuable asset for patients with cancer. So we want to make sure that the time that they spend here is valuable and not just spent waiting for things that we could be doing more quickly. So that's a critical role for our department.
Absolutely. We don't sort of unfortunately expect numbers of cancer diagnoses to be decreasing in the next years, and demand for treatment has increased. And certainly as LRCP becomes more and more busy and more full, they are very grateful to have patients receive their treatments in their own communities. And so our numbers have gone up, and just as an example of what we might have in our clinic over the last year, you can see we have over 1,700 chemotherapy treatments in that time frame, as well as so in addition to 428 consults and follow-up visits. And so, you know, averaging that over our 3 days of chemotherapy, it's a fairly large group of patients that we're managing and continuing to follow. And we'll talk a little bit more about what we do on Thursdays in those patients. But certainly it's an unfortunate trend of increasing diagnoses that we're seeing. And it's so important that we're able to do this close to their home. And we'll sort of touch on that a little bit more.
So as you've heard Carol allude to, a connection with the London Regional Cancer Program. So STEGH has a contract with LRCP, as we shorten it down to be a satellite program with them, which gives us, which allows us to leverage a lot of the knowledge and expertise of their program, and in order to deliver that care closer to home for Elgin County residents. So that's a great advantage for us because they give us support from an IT perspective and from an education and training perspective as well for the staff and for the patients. So most of the patients have either an oncologist or a hematologist at LRCP that they're connected with as well, in addition to receiving care here. So some of their appointments are still in London. We can't get rid of all of those. They still need to follow up directly with their oncologist, but a lot of their appointments and some of their follow-ups are done here as well. The exception to that would be Dr. Panuganti's patients. She runs her medical oncology clinic here at STEGH. So all of her patients' appointments are conducted here very close to home.
And we hear that frequently. Patients are very grateful to be able to decrease their drive time to London, decrease the stress of city driving or extended hours in the city, or needing to find a ride. Parking fees are lower. They have the support of family and friends that are, you know, often close to their homes, also nearby. So we hear those types of comments, and more specifically, we hear comments about how the nurses and the staff knows each person by name. We know them by sight. Our registration clerk often doesn't need to take any information beyond just waving at the patient and knowing their faces. So there's very individualized care based on what the patient's requirements are. And simultaneously, there's always communication between the GPOs here at STEGH and the LRCP team. We have really great lines of communication that are always open, always able to share information back and forth. And so there's definitely a benefit to the continuity of care if they've developed a relationship with us, and now they're able to see us as well as have that direct link to their team at LRCP as well. A lot of our GPOs, as I mentioned before, myself and two of the others also work in the emergency department at STEGH. And as much as we work to keep our patients out of the emergency department, unfortunately, the nature of their conditions often do require assessments in the emergency department during hours that, you know, our clinic isn't open. And that has also become something that we're starting to hear comments about. Thankfulness that somebody that knows their condition, somebody that knows their drug regimen is also able to maybe see them in the emergency department or even up on the floor as a hospitalist. So that's another way that we're able to offer continuity of care in a smaller center than LRCP, where maybe things are a little bit more distant, even geographically.
Okay, so we can offer most of the same treatments that they can at LRCP. The exception to that would be when the drug wastage costs are very high. We get charged for wasting drugs if a patient doesn't need a full dose. They're very expensive drugs, so we try and minimize those costs because we do get charged for that, and we want all of our investment in the drugs to be going to the patient. So, but there is constant communication, as Carol alluded to, between the oncologist, hematologist, pharmacy, and the nursing colleagues between both sites to make sure to make those decisions about treatment regimens and make sure that we have good continuity of care between the follow-up visits and the actual treatment visits. LRCP does support us as well with training. So their educators come on site here to STEGH twice a year for site visits to deliver some hands-on education and troubleshoot issues. They were actually, the educator was just here last week actually teaching the staff about how to manage when chemo drugs leak into peripheral fluids. That's a medical emergency, so how to deal with that. And then how to clean up a spill, which thankfully doesn't happen often, but we want to make sure that our staff are safe and that the patients are safe when that happens, because they are cytotoxic drugs that can be harmful when accessed inappropriately or incorrectly versus how we're giving them as a treatment. Our staff are also invited to all of the virtual learning opportunities that are offered by LRCP and their partners, and that's usually multiple sessions per month. So there's lots of education to make sure that our staff are feeling confident and competent in their roles so that they can deliver the safe care that we want to give to our patients.
The medications that we are giving in a patient's chemotherapy regimen are given via IV infusion for the most part. There are a few exceptions to that. But when that happens, I mean, that's a lot of IV access, a lot of pokes. And so oftentimes we're required to arrange different types of access to a person's to a person in order to be able to give them their medication. So that things like a PIC or a port, we're able to arrange for those to be inserted through ambulatory care, and we have relatively quick access to that. And then we are able to discuss with the patient, but discuss with the patient what their intent is and what the medication is able to offer, and have these kinds of conversations with patients. Is this a curative intent where we're also using surgery and radiation or other modalities to cure this disease, or is this a palliative intent? Are we preventing growth or symptom management with this treatment? And so we're able to have those kinds of conversations in real time with patients as they're going through this and as their levels of tolerance to the medication are varying. We know that these medications have toxic effects and varying levels of toxicity. So our pharmacy spends a lot of time and space within their department to prepare the chemotherapy infusions for patients. And certainly that is one of our main factors as far as availability of chemotherapy clinic days, and as far as numbers of infusions that we can do, is the ability of our pharmacy to prepare these medications safely and have them moved from pharmacy over to our department. As Stacey mentioned, the cost of these medications is quite significant. Cancer Care Ontario is the organization that funds these, and they determine eligibility criteria for coverage of these medications. And as I said before, the pharmacy helps us navigate that, both at LRCP and here at STEGH, so that we are giving these medications in the most effective and efficient way possible.
Okay. So when patients come for their clinical appointments, we'll talk about their clinical appointments and then the treatment appointments as well, because typically you would do one and then the other once a treatment regimen has been decided. So the patient will arrive and check in. They'll get their blood work done and sent to the lab. And then the GPO or the oncologist is going to do an assessment. So, and part of that is education and an assessment about side effects. If the patient had any side effects after the last dose of their regimen, do we need to adjust the dose? Do we need to better manage their symptoms? How do we mitigate those side effects? if we can also provide education about, you know, is there risk to others in their household due to the cytotoxic nature of their drugs? Do they need to use a separate toilet in their house to make sure that there's no cross-contamination with anybody else living there? What are the patient's goals? What are their options? We want to have conversations about those to make sure that no matter what we're doing, we're always meeting the patient's goals and how they want to pursue their treatment for their cancer. And what is the short-term and long-term prognosis that they can expect or look forward to. It's also an opportunity to revisit any previous conversations to make sure that patients have an understanding of the diagnosis and the treatment. My mother had cancer a number of years ago, and she noted that was one thing that was a struggle for her, was that you can't always remember what was said or if you didn't write it down. So that's an opportunity for us to make sure that there's good understanding on the behalf of the patient, so that they can then relay that to their loved ones. And we can review the tolerance, like I said, of the previous chemo dose, and does the patient want to continue? Because sometimes after experiencing those side effects, patients don't want to continue. And again, that goes back to meeting the patient's goals.
So as that information starts to come together, the clinical assessment of the patient and the laboratory results start to filter back, we're able to decide whether we're going to proceed. And if we're deciding to proceed, then there's communication again with the pharmacy, and the pharmacist will order the medication to be prepared. So it's not something that we just have and can just pull out of a cupboard and give to patients. It actually needs to be prepared after that assessment and the blood work have been completed. So the patient will move to the treatment room if there's a chair available. And we try to move patients directly to the chair, but if there's not a chair available, they'll move into the waiting room for a time until those medications are ready. They'll receive their pre-medications if any are required, and then they'll begin their treatment. Most drugs have protocols for how quickly they can be given, for how long the infusion needs to be run over, and protocols for what to do if they begin developing symptoms or side effects while they're in their chairs. So all of those things are assessed and monitored very closely, and following their treatment, their lines are flushed and they're rewrapped and dressed, and instructions are given for or reminders for what to do during the week if things should go sideways. And then they're given a list of their appointments to follow up as far as any imaging, any investigations that need to be done, or their next treatment with us, or their next appointment at LRCP.
So what else do we do? So you heard us mention earlier that Thursdays, we don't give chemo on Thursdays. Ambulatory care is using the pharmacy resources for some medications that we routinely give on Thursdays. So we don't run chemo on Thursdays, but we do offer supportive treatments. So that may mean blood transfusions or electrolyte replacement, iron infusions, to help patients manage the side effects of their chemo and the symptoms of their cancer. So that is run by our RNs, but the physician is on call and is available if there's any questions or concerns, or if there's clarifications to be done for the orders. We also see some other patients who require infusion support that aren't receiving chemotherapy. So we do get some referrals from the community physicians for either a one-time blood transfusion or somebody who needs a routine treatment for a prescribed amount of time that we don't want necessarily going to the emergency department. We can easily facilitate that either in ambulatory or in chemo, depending on the patient. Chemo also supports staff training to access ports. That is a specialized skill. So there's a learning package that staff need to complete, and then they will come and spend 4 hours in the department to learn how to access a port, which is inserted or embedded underneath the skin in place of an IV. So they will practice accessing and de-accessing a number of ports before they would be considered certified. And because we see so many of these patients, we help facilitate that education for other staff as well.
Mm-hmm. So I mentioned before that there are 4 GPOs that are working in the unit right now. As a 12-year veteran of the emergency department, I find that our chemotherapy unit is such a unique and special place to work in the hospital. I think it's a privilege to be able to work there. And one of the things that makes it so unique is that we all have other roles in the hospital and are able to see our patients sort of across the continuum in our site. And it's come up several times with different patients, and they've definitely appreciated the continuity of care, as I mentioned before. So certainly a unique feature of our unit. There's some other things though that make our unit unique, and I just want to spend a little bit of time with Stacey chatting about what we think is special about our unit. We have iPads that patients can use as a way to pass time, to distract them from some of the anxiety or stress that's going on. And they do spend a fair amount of time in a chair often. And so they are able to have some magazine subscriptions or play some games on the iPads or watch some Netflix. Our nursing staff is able to do a lot of the treatment, the blood work, all of that independently. We're not reliant on other staff to come and do those things in our department. So we're trying to always make our flow through the department most efficient, most simple for the patients. We try to reduce the complexity of maneuvering through a large site and keep it as simple and as painless, I guess, as possible.
So we'll talk about a little bit of how we're improving the unit. So over the past 6 months, we've been working on some changes, some big, some small, to improve the experience of both our staff and our patients. And we're fortunate, there are some definite benefits of working in smaller centers, because sometimes change can happen a little more quickly than if you're trying to make change over a larger program. So we recently, just this month actually, we transitioned the medical oncology clinic, that's Dr. Pianuganti's clinic, to Thursdays to allow us to load level our appointments across our chemo days. So on Tuesdays previously, we were trying to run 2 clinics. And if you remember back to the beginning, we only have 3 exam rooms. So that was definitely a challenge. And it created a lot of waiting for our patients. And patients were getting upset. Rightly so, that they were waiting far longer than needed to happen. So that change, we've just done that a couple of weeks ago and has already been fantastic. Staff are very pleased with how it's going, and we've already heard very positive comments from the patients that they can visually see that the clinic is less busy, just because we don't have a Tuesday that's crazy busy and then a couple other days that are less busy. So the patients are definitely enjoying that. We've implemented a float nurse. So a lot of our physicians want to work more independently. They're used to that in Emerge. So the float nurse role allows that nurse to be more available to support the treatment room in terms of getting patients in quicker, relieving for breaks so that care can continue and that we can continue getting patients through the treatment room, as well as supporting on the clinic side if needed. We've started calling all of our new patients each week. So we usually get, actually, I don't want to ballpark a number, but I know this week we've had 3 new patients. So last week, the nurses called each of those new patients to tell them what to expect when they arrive to the clinic. We found back in the spring, patients, when they're going to London, they're told to arrive 1 hour early. And when patients were booked through LRCP into our clinic, they were receiving that same advice to arrive 1 hour early. Because we draw our own blood work and our site is much smaller, that 1 hour is far too much. And patients were waiting for about 45 minutes before their appointment, before they could get in to see the physician. So having them arrive right on time eliminates a lot of unnecessary waiting right off the bat. We also changed our CRN shift to 8 to 4 from 7:30 to 3:30. So that aligns better with some of our other shifts, and it provides more support at the end of the day. Sometimes patients have reactions to the medication and they need to stay a little bit longer than expected. So changing that shift allows us to have good support at the end of the day as well. All right, so our patients are very passionate about giving back, and there's several ways that they give back to our clinic. So the Mike Condi is a former patient of the STEGH chemotherapy clinic, and during his treatment, back about 10 years ago, he started an annual golf tournament that you may have heard of, the Condi Cancer Cup, to support cancer patients in this area in Central Elgin. And then the foundation was formed after he passed away to carry on this legacy. So they support our clinic. Every new patient receives a donated quilt, which can help keep them warm during their treatment or to have at home. And those are donated by staff or by patients who have come through the clinic before. Patients have also donated turbans or wigs in support of other patients who may lose their hair as a result of their treatment and want something to feel more confident in themselves. Information sharing is an important one. By sharing their chemo stories, the information about the experience and the care that they received here at STEGH, that helps promote our program and to help patients just know that they have the option of being treated here versus going to London. And then the STEGH Foundation Gifts of Gratitude. So the chemo team was recently recognized by 3 gifts of gratitude from patients in recognition of the gratitude that they felt for receiving their care from our team.
So all things that make our unit very special and unique, I think, in the hospital. And I did have our nurses help me gather just 2 stories, just briefly, of patients that have moved through our unit. About 6 years ago, we had a patient who came to our unit for treatment, and unfortunately, his story ended with him passing away. But his wife was so thankful and grateful for the care that he received during that time. She became one of our volunteers. She's been a faithful volunteer up until about the last year, when she was also diagnosed with cancer and is now undergoing her own treatment in our unit. She's been very vocal throughout about her appreciation for the care that she's been receiving in our unit, and also when she's had to encounter other healthcare professionals in other departments in the hospital, about being able to receive that continuity of care. And it's been such a really neat experience to see people move through their journey that way, and to be able to be part of those stories with these patients. Another patient that we had was a patient who received chemotherapy at LRCP as well as other treatments, but was coming to us for transfusion support sometimes as often as twice a week. So that was a lot of relationship building and a lot of time together. And the patient's brother also was a patient of ours who unfortunately had passed away. And so it was a sort of a family, we became a family in the chemotherapy unit along with these 2 gentlemen. This patient also eventually got worse, made several trips into the emergency department with multiple admissions, but continuously was very verbal about his appreciation of the familiar faces of the nurses who cross cover in the emergency department and chemotherapy, or the MDs that he saw, helping with his continuity of care, which definitely made a lot of his care smoother and much more direct. He didn't have to explain the whole history. He didn't have to explain his concerns about drug interactions. Staff were up to date about his plans of care. And that was definitely a way that we were able to impact the lives of these 2 men and help make their experiences better in any way that we could while they were going through some pretty significant challenges. So I just wanted to end with those stories as an illustration of the ways that we feel that we're able to care well for our patients in St. Thomas, and just pride for this small unit that's really doing really good things. I think we have excellent nurses. We have a very supportive manager, and it's a unit where, we know our patients, they know us, we know their faces, and it's very personalized care. So I think it's very important that people in our community know that it's there, that that's an option if there's cancer treatments required, and can that will be able to assist and sort of make those visits a little bit simpler for people.
Great, Carol, thank you. That summed it up very nicely. We'll turn it back to Kenzie.
Amazing. So thank you so much for that wonderful presentation, Dr. Harder and Stacey. So we'll now open it up for some questions. So if you want to type in the chat box, that is an option. I can read them out. Or if you want to unmute yourself and ask a question, that is totally okay as well.
I guess we'll take that as a sign that we've included all the right information.
I think so as well. So if no one has any questions, I will turn it back over to Judy to close us out.
Thanks, Kenzie. Carol and Stacey, thank you for sharing your knowledge and expertise with us today. Your presentation exceeded expectations, and I'm sure our participants found your STEGH talk very informative. So informative, they don't have any questions for you. But we are very fortunate to have both of you, your staff, and this service in our hospital here in St. Thomas. STEGH Talks is a series of presentations that the Foundation will be hosting regularly. Please watch for future announcements as we confirm our schedule. And if you have any program suggestions for topics of interest to you and your family, please let us know. Have a great day, and thank you for joining us, everyone. Bye now.
Thank you.
Thanks, everyone. Take care.
Thank you.